Hi everyone, and welcome to the skill building session for Let Data Drive, Better HIV and Sexual Reproductive Health Outcomes for Adolescents. My name's Savvy Brar, and I'm a statistics officer at UNICEF HQ in New York, and I'm going to quickly take you through an introductory presentation. Before we get into the presentation, I want to give you a quick overview of the topics we'll be covering. First, we'll be looking at programming limitations due to insufficient data. We'll also be looking at the importance of data collection, analysis, and use, as well as the types of data and data sources. We'll then go through some examples of how disaggregated data can inform programs, adolescent engagement in data collection, and give you a brief introduction of data champions and our contribution. There are several limitations of programming with insufficient disaggregated data. The first of which being an incomplete understanding of the situation for adolescents, especially at the subnational level and among key populations, which in turn impacts our knowledge related to program coverage gaps or inequities in outcomes across regions or populations. Insufficient disaggregated data also means that we are unable to monitor the progress and adequately tailor programs to respond to differences by sex, age, place of residence, and socioeconomic factors, thus impacting national stakeholders and policymakers who are inadequately equipped to strategically plan and implement programs to improve outcomes for adolescents. Data collection, analysis, and the use of this data and analyses is extremely important. We often say what gets measured gets done. This means that by collecting data at the specific levels and disaggregations that are necessary and actually using this data and analyses, we're then able to inform program planning and implementation efforts. The UN 2030 agenda says to leave no one behind, and leaving no one behind means moving beyond assessing average and aggregate progress towards ensuring progress for all population groups at a disaggregated level. Through data collection and analyses, we can identify data gaps for adolescents and inform immediate program planning needs at the subnational level, especially where national systems need to be improved to integrate adolescent sex and age disaggregated data into routine monitoring. Such data collection, analysis, and the use of this data also informs estimates through population-level denominators and routinely collected numerators from existing service sites, which then in turn facilitate analyses aimed at identifying and addressing program coverage gaps and bottlenecks. There are different types of data and data sources. The two main types of data are quantitative data versus qualitative data. Quantitative data looks at something at a quantity, so usually it's numerical or statistical in nature. Qualitative data looks at quality. It's descriptive data that's based on observations that are usually made through focus group discussions or key informant interviews. There are two main types of data sources: primary data sources and secondary data sources. Primary data sources generate raw quantitative and qualitative data. Some examples of primary data sources are routine health information systems, such as a DHIS2, which look at patient monitoring, population-based surveys, such as a demographic and health survey, or the DHS, the MIX, which is a multiple indicator cluster survey, or the PHIA, which is the population HIV impact assessment. You can also have targeted surveys. Sometimes these are more geared towards key populations, such as an integrated bio and behavioral survey, antenatal care sentinel surveillance for pregnant women, and knowledge, attitudes, and practices surveys as well. You also have modeled estimates through Spectrum or online surveys, which can be conducted through YouReport, Facebook, Line, and WeChat. Secondary data sources produce information through analyzing the raw data. These can be shown through peer-reviewed journal articles, systematic reviews, and academic books. There are several key data challenges that we often face. The first of which being availability of age and sex disaggregated data, especially at the desired frequency, meaning monthly or quarterly data, and at specific geographical locations, meaning the subnational level. There are also issues with data quality, so the accuracy and completeness of data. There are often issues with misclassification, duplication, or poor compliance with reporting requirements. Another issue that we often face is related to non-routine data collection. This is often a challenge with population-based surveys, which are only collected every 3 to 5 years. Therefore, the data cannot detect small changes or changes over short periods of time. Another issue is secure and ethical data collection. This is often a challenge with key population surveys, where we're inquiring about sensitive behaviors. We need to ensure that we have secure data collection and follow ethical protocols to protect subjects, especially following a rights-based approach. The use of data is also another issue that we often face. Sometimes when we're looking at coverage, we need to be using a survey-based denominator, but instead we're looking at the programmatic denominator. And lastly, modeled estimates. There is some degree of uncertainty related to modeled estimates. And as modeling improves and the assumptions improve, thus the estimates themselves also improve. Insufficient or limited disaggregated data has huge repercussions for programming. For example, say in a country the ART coverage is moderate to high, but we only know that that's among all adults 15 plus. In this country, in reality, adolescents and young people have low ART coverage. But the national high ART coverage among adults 15 plus masks or hides the reality among adolescents and young people. This can impact ART procurement, such as the regimens that might be more preferred and tolerated by adolescents and young people compared to their adult counterparts. Lack of disaggregated data can also impact any necessary adaptations to services that might be required, such as adolescent-friendly health services and related trainings for healthcare workers, as well as for specifically tailored services for subpopulations, specific age groups, male versus female, as well as key populations. Without disaggregated data, we also have issues in understanding the areas that have lowest ART coverage subnationally, for example, districts, and where to focus our efforts. We also are not able to deep dive into issues affecting ART coverage. For example, in this country, where we know there's low ART coverage among adolescents and young people, we have issues understanding why that's the case. Is it due to lack of testing? Is it due to issues with linkages to care? And because we don't fully understand the issues behind ART coverage, we then can't advocate for policy change. Now we're going to go through an example of how age and sex disaggregated data has informed programs through All In Kenya. All In was launched in 6 high HIV burden counties in Kenya in February 2015 to improve strategic information related to adolescents living with HIV. A country assessment was conducted, and it produced subnational age disaggregated HIV estimates using proportions extracted from health facility electronic medical records and registers and estimation and projection package EPP spectrum modeling. The findings were that there is limited availability of age disaggregated data, and a lack of data presented major obstacles to designing and/or implementing programs needed to improve outcomes for adolescents. In addition, there was an alarming increase in the number of new HIV infections among adolescents. Nearly 25% of all new infections among those aged 10 to 19 years, and 62% of which took place in 6 of 47 counties, in addition to low uptake of HIV testing and low ART coverage. The findings led to important discussions and government commitment to review and scale up targeted programming for adolescents and to address programmatic gaps that were identified. There were also improvements in data collection tools, such as the HMIS or the DHIS2, EPP spectrum estimates. There was an updated KEN-FIA, the Population HIV Impact Assessment, and new viral load monitoring systems that included age disaggregations. We are now going to discuss the Lesotho Let Youth Lead program, which is an example of engaging adolescents in data collection. Let Youth Lead is a peer-led intervention to improve the quality of adolescent-friendly health services. The program is being implemented in 5 out of 10 districts and has a current coverage of 20% of health centers in the country. During the first year of implementation, there were significant achievements. 140 youth advocates were trained on social accountability, sexual reproductive health and rights, and adolescent-friendly health services standards. The main strategies used to improve the quality of adolescent-friendly health services were community mobilization, adolescent participation, community outreach, and peer support. Through the program, social accountability scorecards were generated, and 25 community action plans were developed and monitored. In addition, as a result of the community action plans, all health centers have a young person participating in the health center committees. Facilities change their opening hours to accommodate adolescents and young people, or introduce specialized days for adolescent services where time adjustment was not possible. I will now take you through the interventions theory of change. Several underlying issues that impact adolescents in Lesotho are limited availability and utilization of disaggregated data, high HIV incidence among adolescents, especially among adolescent girls and young women, and quality of social services, which are a deterrent for adolescents to access services. The Let Youth Lead program hinges on evidence generation, C4D, adolescent participation, and advocacy to achieve the desired results. Evidence generation and participation are critical to create the accountability loop where the evidence guides an action and a response. The evidence is compiled by youth advocates through a community scorecard. With the youth's collective voices, the youth advocates rate their satisfaction on the health center's performance against the adolescent-friendly health services standards. Through dialogue and interface meetings, health workers and youth advocates agree on a common score and develop a community action plan, which is monitored quarterly through the adolescent and government interactions. Actions that are beyond the health center's control are escalated to the district interface and ultimately, if required, to the national interface meeting. The intervention is expected to empower adolescents and improve their knowledge of their SRHR, or sexual reproductive health and rights, improve health workers' capacity to provide adolescent-friendly health services, and improve health center transparency, governance, and young people's participation in decision-making. Ultimately, through stakeholders and partner contributions, it will contribute to improved quality of healthcare, to health systems sensitive to adolescent issues, to parents and caregivers having a greater understanding with adolescent sexuality education, and higher demand for adolescent-friendly health services among adolescents and young people, thus leading to adolescents having reduced risk of HIV and improved health outcomes. Now, as we come to the end of this presentation, I'd like to very briefly draw your attention to this term, data champions. Data champions are individuals who are passionate about using data effectively and promoting data best practice. They understand the potential of data and know how to unleash it responsibly, to close data gaps for adolescents and program planning needs, and advocate for data-driven decision-making. We hope that by the end of today's skill building session, you'll truly understand what it means to be a data champion and how you can contribute to your communities as such.